Welcome, everybody. Thank you so much for being here. I have the honor, really, to be on the same stage with Dr. Les Shaw, who is an expert in biomarker research. Throughout his career, he has been focused on developing, validating, and implementing these biomarkers in clinical trials, clinical studies, with the goal of actually transitioning these biomarkers into clinical practice. I need my notes for the rest because he's a busy man. He's professor of pathology and laboratory medicine at the University of Pennsylvania Hospital. He's director of clinical toxicology lab at University of Pennsylvania Perelman School of Medicine. And in addition, in his spare time, I guess, he is a director of Alzheimer's Disease Neuroimaging Initiative, or ADNI, Biomarker Core Laboratory at University of Pennsylvania. Dr. Shaw has brought significant contribution to the field of biomarkers, and he's very knowledgeable. So please have questions for him. Probably if he starts talking, you are going to be here for a while, but you are going to learn a lot. So please help me welcome our speaker to the stage. So just to set the stage a little, I'm just going to introduce Alzheimer's disease to you. It's not a new disease. However, what is new is the fact that it evolves throughout the continuum. It's not something that appears overnight. It starts with the asymptomatic stage where the pathology starts accumulating. And then biomarkers that are significant for this pathology, such as amyloid and tau, these are the proteins that are the hallmark of this Alzheimer's disease. They start changing, and as the disease progresses, patients start having symptoms. It's called memory cognitive impairment. That's the earliest symptomatic stage. And that goes gradually towards mild Alzheimer's dementia, which then progresses towards moderate Alzheimer's dementia and then severe dementia. This is a fatal disease. So the sooner we diagnose, the better it is. Not just because there are treatments right now for the early stage of symptomatic disease. What you see in green actually on the slide are the early symptomatic disease where these drugs are most effective, but also because you can actually do something in terms of lifestyle changes to modify the progression of this disease. So Dr. Shaw, in terms of lifestyle changes, before we get into all these biomarkers and therapies and future, in terms of lifestyle changes, give us a hope that we can do something about preventing this disease from progressing.
Yeah, one of the things that impressed me a lot about 3 weeks ago was a presentation made on CNN on the FINGERS trial. And the FINGERS trial is a non-pharmaceutical treatment of individuals in whom it is believed they have Alzheimer's disease to delay the progression of that disease through the intervention of lifestyle changes, nutritional changes, cognitive skill training, and things of that sort. The first patient who was described in that presentation was a grandmother, an Italian grandmother aged about 75, who had many grandchildren, had a wonderful life. Her family recognized some decline in her cognitive skills, in her memory. So they actually linked her with the FINGERS trial, which is a formal study of these kinds of changes and the impact they have on these people. 5 years later, so Sanjay Gupta coordinated this program and followed this patient for 5 years after enrollment in that FINGERS trial. And the joy in that grandmother's face 5 years later, her ability to communicate, her ability to be a grandmother was very touching, very, very touching. But the point about that is that it was awe-inspiring that we have a lot of reason to be hopeful when it comes to Alzheimer's disease, recognizing it and intervening meaningfully. One way of which would be this way. There are now new drugs to treat one of the causes of the disease, namely amyloid plaque burden. And so lecanemab or Leqembi and donanemab, and I forget its
Kisanla. It's a hard name to remember.
so are two FDA-approved drugs that can actually modify the progression of the disease modestly. But the main point is we're at a point in time where there's a great deal of hope that we can meaningfully treat this disease.
Thank you. So right now, a patient that has symptoms and goes to his doctor, let's say he presents to the primary care physician with symptoms, they will eventually do a cognitive assessment. And then if the results of the cognitive assessment say the patient has cognitive decline, he will be referred, hopefully, to a neurologist. And it's at the neurology or memory care clinic where they can do additional, more complex investigations to figure out the cause of this disease, of the symptoms. So they will do an MRI, imaging, right? But they can also do laboratory tests to rule out other causes for this cognitive decline. However, right now we have the ability in the laboratory and in the clinics to do biomarker testing. So that will result in patients being able to have a diagnosis. The accuracy of diagnosis will improve from 70% to over 90%. But also they will be able to refer these, clinicians will be able to refer these patients for therapy as appropriate. Dr. Shaw, in terms of diagnostic tools for the laboratories and for the clinicians, what do they have available that is FDA approved at this time?
Yeah, at this time today, your clinical laboratory can provide CSF testing for two major important markers of Alzheimer's disease, namely amyloid plaque burden and tau pathology, tau tangle burden, by measurement of A-beta 42 and by measurement of phosphorylated tau and total tau, a measure of amyloid plaque burden, a measure of tau tangle pathology. The tests that are available are on two major platforms, the Roche Elexis platform and the Fujirebio LumiPulse. These tests are FDA approved and they're rock solid for reliability, robustness, for detecting the presence or the absence of those two key components of Alzheimer's disease, amyloid plaque burden and tau tangle pathology. So if a physician and patient have worked together with the family and so on, and if they've come to the point of saying, we've done all the clinical testing, we've done all of the things that we can do of that nature, and I still am not sure if you have Alzheimer's disease, maybe you have some other cause of your memory lapse or of your cognitive decline, and so on. And so in that particular case, this kind of testing is great for ruling in or ruling out the presence of Alzheimer's disease pathology. And We have done studies using the Roche Alexis for about 5 years in the Alzheimer's Disease Neuroimaging Initiative. All of the data generated are available online on the ADNI website for anyone who wishes to interrogate it. But from those studies over that many years, this is rugged and reliable measurement.
So this hasn't happened overnight, right? This is the result of decades of research in biomarker development. I'm just wondering if you can comment on the quality characteristics for the CSF biomarkers in terms of robustness, standardization, what has been achieved
Yeah.
in the past decades to give us this reliable test nowadays?
So, as you were saying, it was a couple of decades of work from the very beginning where we had ELISA-type immunoassays, home brew tests, and so forth and so on. It is now possible to achieve reproducibility of about 5% coefficient of variation. That's a pretty tight reproducibility. And then over the 5 years of studies that we did, we cross-checked for lot-to-lot performance, such a hugely important part of documenting robustness. And I can say that these tests have met our criteria for that kind of testing of robustness.
Thank you. So moving on from CSF, now the field is also moving on quite fast towards the blood-based biomarkers. It's not happening immediately, but it's been, again, the result of many years of research, but they are coming from behind like a wave, like a new wave of the future, and people are getting excited about them. Would you mind commenting on
Sure.
where are we with these blood-based biomarkers and what is needed?
Yeah. Yes. So for many years, with many different attempts, measuring meaningfully A beta 42 and 40, for example, in plasma was going nowhere. The results in one study showed they were different. In another study, they were not different. It was all over the place. And most of us, myself included, were very skeptical that we would ever reach a point of having what I could proudly say are really good tests for AD biomarkers. In 2017 and in 2018, two different groups using mass spectrometry measured 42 and 40 in plasma, and both groups independently showed about a 10 to 15% difference, lower in the affected and than the non-affected individuals. Not a big difference. And as clinical chemists, when we say 10 or 15%, are you kidding me? Nevertheless, the fact that two different groups were able to demonstrate this finally convinced a lot of folks, maybe we better take a closer look at these plasma AD biomarkers after all. Soon thereafter, another different study showed surprisingly, and to some people shockingly, that phosphorylated tau 181, which we measured all the time in CSF, when measured in plasma, had about a 50 to 75% difference in affected versus not. So higher in the affected compared to the non-affected. Phosphorylated tau 181. That set a firestorm of activity, because so the objective measure that it was compared to was amyloid PET. Phosphorylated tau, amyloid PET. So at that point, in 2018 or 2019 or so, it looked like we have a real ability to start to reach amyloid PET-like ability by measuring phosphorylated tau in plasma. Another year later or so, folks were testing different isoforms of phosphorylated tau, pTau 217 and pTau 231. And what was discovered is that the 217 had an even greater dynamic range between affected and non-affected, twofold. Now, the firestorm really started to blow up practically. And so you have paper after paper, study after study after study, different populations and the like, all giving rise to the same general conclusion. pTau 217 looks like a winner when you're looking at affected versus not affected in that way. We all know, people have done studies, know that it's one thing to make that initial finding and it's another to have a test that really works. So in the intervening years, several years, more rigorous testing, evaluation, getting these tests onto automated platforms like the Roche Alexis, the Fuji Rebio LumiPulse. Now you're starting to really talk about the realistic possibility of going those next steps. So, we and others have been engaged in serious work of characterizing further not only the performance analytically, which is very important, but the ability to detect disease versus not. And so now there's a preprint which can be made available to anybody who wishes of a major study done in the Alzheimer's Disease Neuroimaging Initiative, sponsored by the Foundation of the NIH, Biomarker Consortium, involving 320 some odd patients, each with 3 serial in time plasma samples and 3 serial in time corresponding amyloid PET scans. The preprint describes in exquisite detail the comparison of 4 different pTau 217 assays, 1 mass spec, 3 immunoassay, 2 different pTau 181 immunoassays, and then 2 different neurofilament light and 2 different glial fibrillary acidic protein measurements in the same individuals with over 1,100 different plasma samples across those individuals. And that study shows resoundingly pTau 217 is the one related to amyloid PET, but not only amyloid PET, to tau PET, at least the early phases of tau abnormalities as reflected by tau PET. Cerebral shrinking of the brain by MRI, and then cognitive decline. Those 4 elements, pTau 217 at the top of the class. The data is available to download and to play with if you wish, but the preprint of the study, which is exquisitely detailed, is available to anybody. So I am bullish, I'll be very honest with you, about the prospects for tests like this to become clinically available. The good news with respect to pTau 217 that we and others have discovered is that it's relatively stable and easy to work with as far as pre-analytical issues. So it has the earmarks, still have a lot of work to do, all the earmarks of a test that will become used clinically, measured in plasma. So what are the challenges? Among the challenges are we need to learn a lot more about how our tests perform, not only in these dedicated clinical trial situations where we have, for example, in the ADNI study, half of the individuals are amyloid positive, half negative. If I go to the community, I may have 10% positivity or 5. So the prevalence of the disease will be way down as we apply these tests more broadly. So we need to do studies to actually see how the performance is in this more general setting. Those studies are ongoing, and there's a major commitment there. A second issue, ethnicity. For a long time, virtually all studies were not representing the population at large. We're largely 90% plus made up of Caucasians and not a representation of our society. That's changing, but it takes time. But it is changing. There is a great recognition, and there's a great deal of support by the National Institute on Aging, for example, to be inclusive in the studies that we're doing. So we in the ADNI study are, clinical trialists with treatment trials are, and so on. So I'm very cautiously, or not cautiously, optimistic that we're going to see a lot of progress within the next couple of years in this domain.
So that brings me to another question. In terms of blood-based biomarkers, there are certain complexities. People are excited, and it's definitely something that we will have in the future. You mentioned the need for additional studies, and I just wanted to point out to where can these biomarkers fit in the patient pathway. And in addition to, so they can be like screening tests, they can be to rule out, right? They can be confirmatory tests to rule in.
Yeah.
They can be just, a test with one cutoff to do both in a balanced sensitivity, specificity kind of way. They can be used in secondary care. They can be used in primary care. You brought up the prevalence issue that we need to watch out for, and the need for real-world studies. So would you mind summarizing your thoughts in where they would fit best in the patient pathway?
Yeah. This is a very, very challenging question. I tend to be conservative when thinking, especially at this early stage, of how this kind of testing would roll out, so to speak. Ideally, it would roll out in the setting where experts are involved in interpreting the results. After all, revealing to a patient, communicating to a patient and the caregiver information about whether or not AD is present is no trivial matter. We all understand that. And so we're going to have to step, my opinion, very carefully through the process of the communication of the results. Therefore, in response to your question, it's my opinion that not in primary care, but in more memory disorder setting, at least at the beginning, until we really get to know how this all will work out. We're dealing with patients. We're dealing with people with potentially devastating disease, and we've got to be extremely careful how we handle this. All the more reason and motivation that before tests like this are released for use, they have to be validated extraordinarily carefully. This was done with CSF, I have to say, and it has worked very, very well. We have really reliable and rugged tests for the CSF-AD biomarkers. We want to achieve the same level of ruggedness and reliability for plasma-based biomarker tests.
Thank you, Dr. Shaw. So we only have 3 minutes, and I want to give the audience a chance for asking questions.
If you have a question, please just raise your hand and we'll bring a microphone to you.
Thank you, Dr. Shah. Very informative. So my question is around pTau 217. Do you see it initially being more of a rule in or rule out test as it becomes available clinically?
We're going to have to really assess that with lots of data. So let's talk about cutoffs. The current thinking in this field is to have 2 cutoffs. One, that would be a higher value, that would be likely to be a more rule-in result. In other words, if a pTau is above the upper cutoff, it's pretty strong statistically that is consistent with AD. On the other hand, if we're at that lower end where, and let's say someone is below that lower level, you're pretty good bet to rule out pathology. But I say it very cautiously. I would only put that in writing after I see a lot more study data testing that very question. But those are my preliminary thoughts at this moment.
So we have a test with 2 cutoffs,
Yeah.
one that rules out and one that rules in.
Right.
In between those 2 cutoffs, the results,
the
the
indeterminate
zone,
zone.
yes.
Yeah, a lot of attention being paid to the indeterminate zone. And so most studies now are reporting this. The ultimate goal of all the studies, if a test is going to prove to be good,
Yes.
is to have 20% or fewer in that indeterminate zone. Now, if you're a doctor working with a patient and caregiver and someone tests in that indeterminate zone, what do you do now? Depending upon the patient and the circumstances, would be CSF testing, if there's still a need to rule in or out, and or amyloid PET testing. That's what I see.
So you would see actually the blood-based biomarkers, the CSF biomarkers, and the imaging being all used as needed in the future as well.
That's the current thinking. Again, we've got a lot more work to do to really refine our ability to interpret these questions. But that's where we're at right now.
Thank you. Yes, please.
Hi, Dr. Shaw. Thank you so much for being here, first and foremost. You touched a little bit on ethnicity and just the data being inconclusive there. Are there other risk factors that have been identified or trends to increase a person's chances of being diagnosed with Alzheimer's? And then just a more general question, I'm really curious to hear your perspective on what a blood-based test means for patients, for the community looking for answers and increasing access to testing. Can you talk a little bit about that?
Yes. Firstly, the first part of your question regarding interpretation challenges. We mentioned ethnicity. That's one. comorbidities, renal dysfunction, body mass index, age is important. We have to understand how biomarkers naturally change with age and so on. One of the important challenges for us as laboratorians will be to be as transparent as possible as to where did we get these ranges that we're citing for interpretation. That has got to be part of the conversation. I dare say that when we introduced CSF testing at the University of Pennsylvania about a year when they became available, 8 to 10 months ago, there was a lot of crosstalk with our clinical colleagues, some of whom are doing this very research as well. So they have an innate kind of sense of understanding things. What is the basis for the cutoffs? How do we interpret? What are the foibles in that interpretation? And that's one of the reasons why I'm an advocate, at the start at least, that when we introduce the blood-based biomarker testing, it be done in the context of experts clinically. As far as ethnicity is concerned, we have a major commitment to, for example, compare these biomarkers' performance in African Americans versus Caucasians. The clinical diagnosis of AD is limited, and we need biomarkers. But when the first studies were being done with CSF and ethnicity, African American, Caucasian, people were saying, tau is lower in these folks, and amyloid is more normal. Well, what does that tell you? It probably tells you they don't have as much Alzheimer's as you thought they did, but they may have something else causing their cognitive issues. Those are the sorts of questions and challenges that we're just beginning to take a closer and closer look. The good news is that organizations like the National Institute on Aging, the pharmaceutical companies, are much more finely tuned into this. And so in the ADNI study, for example, a lot of resources being spent to recruit into the underserved minorities, Latinas, Latino and Latinxes, African Americans, Asians. Let's be much more representative of our population. So we've got a lot of homework to do to really answer your question fully.
I just wanted to add from the manufacturer of IVD perspective that when we do design these registration clinical trials, we do it with a mindset that we have to be inclusive of a certain percentage of diverse population, which is representative of the United States population. So that is the idea, and we select actually the sites based on that criteria. Where do we have to go, in which communities do we have to go to ensure that they have the ability to enroll more Hispanics, more Asian, more African Americans. So we have that kind of diversity in our trials and reliable data to present to our customers. We ran out of time. Unless there is another urgent question, I want to thank you all, and mostly I want to thank you, Dr. Shaw.
Sure.
He has been amazing, not just because he's amazing every day, but today he has traveled actually from Philadelphia, from AIC, to bring us novel knowledge from that conference. He flew in today. He just gave a talk, the session in 402, and now another one here, and he's flying back today. So Dr. Shaw, I'm amazed at your energy, and I wish you the best. Thank you so much.